Our focus now is on really dissemination and then validation of the new guidelines over time, as well as eventually an update, probably in several years. So on the dissemination front, we recognize that the guideline is long and complex, and so we're developing simplified tools, including pocket references that simplify the key points in the guideline. We're looking to translate it into several other major languages over the next several months, and to present it at multiple international meetings and settings where local societies can also have opportunity to interact with the guideline writing group and ask questions and talk about how clinical decision making might be done. We also recognize the importance of further developing practice tools such as mobile apps, which will be coming out over the coming, probably this summer or fall, to facilitate the use of the different staging tools. There already is one for Wi-Fi. There'll be one developing for glass for the anatomic staging that will enable people at the point of care of their angiogram to get the calculated stage, and also one for survival prediction, which is based on the VQI survival model. So those will be coming out in the next few months. And then I think going forward, we need to validate, particularly some of the newer staging systems, to collect data prospectively from around the world, really, to see if these staging systems are accurate or see if they can be simplified or modified with real outcomes data. So that's really where our focus is. We anticipate maybe in about 3 years, with the coming out of the reports from BEST CLI and Basel 2 and 3, as well as these prospective cohort studies, that there'll be a need to update this guideline. The Katsanos meta-analysis data on paclitaxel devices has put the field in a bit of a quandary, and the FDA is going to be reconvening next week to look at updated analysis from the randomized trials. And based on everything that's been posted so far, it looks like those analyses will continue to show that there's a higher mortality risk over the long term in people that were treated with these devices in the randomized trials. There have been other registry studies that have come out, including from individual device manufacturers, that have not shown this. However, I think it's hard to trump the randomized data in terms of the possible risk to patients and safety. So my guess is that based on what we see, the current FDA position will probably not change all that much. They may actually do something like add a warning to the label. I don't think that the devices will be withdrawn from the field, but one will need to continue to carefully consider their use and inform patients about the increased mortality risk. Having said that, I think that all of that data really stems from claudication patients, and I think for many of us, that risk-benefit ratio in claudication may be a little difficult to take on, particularly since we have other choices, both endovascular and otherwise, to treat those patients. So, in terms of CLTI, though, I think that there still remains a great unmet need to improve the outcomes of endovascular therapy. And so our writing group specifically looked at this question and felt that ongoing clinical trials that are appropriately monitored and also that have adequate long-term follow-up and survival opportunities should continue to go forward, because there's an unmet need in CLTI and because the data to date doesn't really reflect that population. Outside of appropriately monitored clinical trials, I think as a provider I would be very cautious. There are other options to use, and the difficult conversation with patients about increased mortality, particularly for claudication, I think makes it a challenge to use those in everyday practice. But ongoing trials, I think, is appropriately ethical to continue.